Hello, I'm Jay Imes from the Ohio State University's Wexner Medical Center. Welcome to the American Journal of Obstetrics and Gynecology In the Spotlight featured article for the month of June. This month's featured article is entitled Implications of Sleep-Disordered Breathing in Pregnancy. The article is authored by Dr. Francesca Bacco from Magee Women's Hospital at the University of Pittsburgh, and her co-authors, Drs. Wang, Z, Gonzalez, Lim, and Grobman from North Shore Health System Pritzker School of Medicine and the University of Chicago, and the Feinberg School of Medicine at Northwestern University, also in Chicago. This article is important for obstetrician gynecologists to know about because it relates to preeclampsia. Yes, you heard that right. Sleep-disordered breathing may lead to preeclampsia. Recent research has suggested that sleep-disordered breathing could be an important underlying cause of preeclampsia. Most studies that have reported a link between sleep-disordered breathing and cardiovascular risk have been performed in non-pregnant populations. But there have also been some observational reports of increased risk of adverse pregnancy outcomes such as preeclampsia, gestational diabetes, and preterm birth in women with disordered breathing while sleeping. The presumed linkage to preeclampsia may be related to transient hypertension induced by hypoxic episodes during sleep. If this were to be confirmed by larger prospective studies, new pathways to prevention of preeclampsia might be opened. This study is among the first to gather data prospectively from pregnant women to test the hypothesis that women with this documented sleep-disordered breathing have increased rates of preeclampsia or other adverse pregnancy outcomes. The authors enrolled women at 2 medical centers with known risk factors for preeclampsia, including women with a body mass index of 30 kilograms per meter squared or more, chronic hypertension, a prior pregnancy complicated by preeclampsia, pregestational diabetes, or twins. Women who consented to the study were asked to wear a wristwatch-like device to gather data needed to detect sleep-disordered breathing, including pulse oximetry, oxyhemoglobin saturation, and episodes of apnea and shallow breathing. These data are used to calculate the apnea-hypopnea index, or AHI, which is the measure used to determine the diagnosis of sleep-disordered breathing. Participants were asked to wear the device throughout the night twice during pregnancy, first between 6 and 20 weeks, and again between 28 and 37 weeks gestation. The primary outcome was the relation of adverse pregnancy outcomes defined by AJOG criteria to sleep-disordered breathing diagnosed by an elevated AHI of 5 or more. Of 233 women who consented to participate, 188 completed the early pregnancy sleep study and 128 completed both sleep monitoring sessions with satisfactory recordings. 62% of study subjects were obese, 57% had pregestational diabetes, and 30% had pre-pregnancy hypertension. 15% had preeclampsia in a previous pregnancy, and 6% had twins. More than half of these women had more than one qualifying risk factor. 21% of women had mild sleep-disordered breathing, and 9% had moderate or severe sleep-disordered breathing detected in early pregnancy. Rates increased to 35% with mild and 12% with moderate or severe disordered breathing in late pregnancy. Preeclampsia was diagnosed in 17.6% of enrollees, but there was no relationship between sleep-disordered breathing and preeclampsia. There was also no relation between sleep-disordered breathing and preterm birth or extremes of birth weight below the 5th or above the 95th percentile. However, there was a relation observed between sleep-disordered breathing and gestational diabetes, with adjusted odd ratios of 1.5 and 3.6 for gestational diabetes in women with sleep-disordered breathing detected in early and late pregnancy, respectively. The conclusion of greatest importance to to obstetrician gynecologists is the absence of any evidence of a relation between sleep-disordered breathing and preeclampsia. Why is this the key finding? Because the causes and means to prevent preeclampsia are unknown, and any promising association that might lead to prevention warrants our attention. In the past, we obstetricians have been eager to adopt treatments aimed at any risk factor or test that might reduce the risk of preeclampsia, recommending, for instance, supplements with calcium, vitamin C or E, antioxidants, and heparin, all based on evidence of associations, but without waiting for prospective interventional studies that almost without exception showed no reduction in the incidence of preeclampsia or other poor pregnancy outcomes. This study is not large enough to answer the question of whether sleep-disordered breathing is somehow related to preeclampsia, but it does allow us to say that screening women with these risk factors for disordered breathing during sleep is not warranted at the present